Hello, everybody, and I'm assuming everyone's ghrelin levels are a little low and maybe a little bit of reactive hypoglycemia. So if you do want to stand up and stretch for a second, I can wait because I know it's a long day, and I know we have a lot of breaks. And as people are standing, I can sort of just get started as well. Does this one work here? Yep. Okay. So this is just a statement about the content of this. This is my content, and I have no idea what this is on the exam. I took the exam 2012 or 13. I forget the first time it was taken. So a lot has changed, and there's a lot of pathophysiology, as you just went through 2 excellent lectures. So good luck with that. But one thing that's, I don't mean that that way, but it's difficult. It's a lot to ingest mentally. Drugs are part of it. So some of the lecture today is going to really just talk about what's probably going to be on the test, not sort of what we see in clinical practice, though I'm open to entertaining any questions. So I'm going to get started. You guys can have a seat or stand up, depending on who is behind you. They might not like that. So let's see, advancing slide. All right, push the wrong button. I do have no disclosures. And these are the topics I'm going to go over. And Dr. Seacat has done an excellent job. I already peppered some of my talk. So some of this might be a little bit of review. But I'm basically going to specifically talk about meds, talk about the history of the meds, current anti-obesity medications, both FDA approved and off-label, a little bit about dietary supplements. I don't think too much will be spoken to, but I'll show a couple graphs on that. The efficacy, indication, counterindications, and safety. These are things that are all they're going to be easy exam questions. A little bit about protocols and REMS, and then weight-promoting medications, which was just touched on. Certainly we know that there's a large treatment gap that exists. We know medications can sort of fill that gap, and that's where the clinical pathway is going. But why is it that medications aren't as more commonly used? Certainly we see history of the medications. Thyroid was used back in the early 1900s. We had the first amphetamine come along in the 1930s, and then sort of the more modern day medications, starting with Phentermine, which is the most commonly prescribed medication, came around the late 50s. So really we're looking at about 65 years of history, and you see a table here looking at the approved medications for weight loss. As you can see that most of them really came in the sort of amphetamines area, and most of the early medications concentrated in the adrenergic system, thinking that generally thinking that if people are overweight because they eat too much, let's really give them something that's going to cut their appetite. And you'll still see patients that I'm sure you have that just want their appetite to go away. But we know, obviously, that's not the approach to take clinically. Again, and these are some of the table. So I'm going to pepper some of my questions in throughout the talk here. So which one of the following statements is true about anti-obesity medications? Fenfluramine and Phentermine was removed in the 1990s because of increased risk of myocardial infarctions. Sibutramine was removed from the market due to increased risk of renal failure in patients with cardiovascular disease. Rimonabant was pulled from the market because of increased risk of neuropsychiatric events. Or D, dexfenfluramine was removed because of increased risk of cerebral vascular events. We don't have a system to do automation, but maybe who thinks it's A? Raise your hands by hands. Who thinks it's B? How about C? And what about D? All right. So C is the answer, and we'll get to this in a second. We know that in 1997, there were several cases of valvular heart disease that led to congestive heart failure and death in a few, and this was reported. And fen-phen, which was really not an approved combination, but it was used in combination, and patients still talk about it, was pulled from the market because of this increased valvulopathy. And it was actually the serotonin, as I'll go over today, it was the serotonin 2B receptors that were agonized by this fenfluramine, which really led to the valvular problems. Just before 2010, something that was approved in Europe and was not approved in the US, rimonabant, which really worked through the endocannabinoid system, it led to increased suicide ideations, and that was pulled from the market, and it was never brought to the US. And lastly, one of the three medications that was used at the time, sibutramine or Meridia, which I won't talk about in depth today, which really looked, its mechanism of action mainly was with norepinephrine and dopamine, but it was studied in the trial called the SCOUT trial. It was studied in patients who had increased risk of cardiovascular risk, and it showed in that population, people with diabetes, cardiovascular disease over the age of 55 and cardiovascular disease, about a 19% increase in MI or cardiovascular events. Here's another a chart just looking at things that were withdrawal, drugs that were used with obesity here, and we see, we see here, pulmonary hypertension was mainly the dexfen and fenfluramine, sibutramine I just went over, and rimonabant I just went over. But this is a good sort of list of just understanding the history, and I think the history of medications really it sort of paints a similar picture of how we've thought about treating obesity and how we think about obesity as a disease. It's changed. A lot of times people think about obesity medications as just diet pills. Again, looking at the only thing that we need to do is decrease somebody's food intake. But we've heard two lovely lectures just recently with Dr. Seacat showing that there's many different ways that people lose weight, and there's many different causes of weight gain. So these sort of misconceptions have been pervasive throughout clinical practice of medicine, and thinking about medications as an easy way out or not effective, or having too many side effects. And I don't know how many of you, but I feel that I talk about side effects, and I want my patients to know that. But if you think about cardiologists or other disease states like hypertension, how many physicians really talk about the side effects of all these medications compared to how we talk about side effects of anti-obesity medications? And I think right in there we see a little bit of why weight stigma is occurring, and I think it's pervasive. Anyway, question 2. Which one of the following neurotransmitters is neutral? And as I go through them, you can raise your hands if you think it's a correct answer. A, histamine. B, dopamine. C, norepinephrine. And D, glutamate. All right. Glutamate it is. So we've just gone through sort of these interacting pathways. I'm not going to talk any more about it for the sake of time, and it's been well discussed already. But certainly drugs are targeting both the periphery and the central areas where weight is regulated. This is just a table looking at the effects and where things, in terms of the mechanisms of actions of medications. And primarily they're working in that sort of the yin-yang in the hypothalamus and the arcuate nucleus at the palm C, as well as the NPY neurons. And this is where most drugs are targeted. Again, these are testable. We think that most of the medications should target these areas that regulate weight. And you see now, rather than the adrenergic system, medications are primarily looking at the hypothalamus and brainstem as well as the periphery. And the thought is that these drugs alter the physiology, and it's not really just let's give somebody a medication to alter their own behaviors, thinking that behaviors is the underlying theme of why they've gained weight. And we see potential mechanisms here of action of both current as well as future medications. And maybe they do increase the adherence of mitigating some of the biological and genetic factors. So maybe adding a GLP-1 agonist like liraglutide to somebody's regimen after they've lost a lot of weight makes sense, because maybe some of their GLP-1 has decreased with weight loss. These are the current medications that are FDA approved. We see phentermine, diethylpropion, and phendimetrazine, and then we see many of the other ones that are Orlistat, and then the last four are ones that are recently approved. And then there's also medications that have been well studied for weight loss, but these are not approved for obesity, and we see that primarily the disease states that they are used for. And you can bucket them in this way as well in terms of adrenergic, anti-epileptic, anti-diabetic, or other. Again, I'll go through these today. Since this is a board review course, I'm not really going to go into all the clinical trials to show you all the differences of weight effects of these medications. This is sort of a summary slide of many different trials that have been lumped into both the FDA approved on the left and the off-label uses of medications on the right. And you see that, and this is in kilograms, these aren't too exciting if you just look at trying to help somebody lose 3 kilograms after a year, and most of these studies are at least a year long. So, on the surface, these medications don't look like they're effective, but we know that they are effective in some. For example, this is a trial that looked at lorcaserin, which is a medication that increases serotonin in the brain, which I'll go into. But you see the wide variety of how the subjects in the study responded, both to placebo as well as to drug. And I think this is where we have to really look at our patients and see how well they're doing and from a weight perspective. And if they're doing well, we should think about using the medication, continuing it. But if they're not, I think the important thing is to not continue to use the medication. And with the same drug, this is an interesting little study, and it looked at both on the right here. Whoops, sorry. Excuse me. Back. Looking for my green. Oh yeah. Okay. Thank you for understanding my left and right here. So they looked at people who responded very well to either placebo or drug at about 12 weeks. And if they had lost weight after 12 weeks, they continued to study them. And it showed basically those who lost weight after 12 weeks could continue to lose weight and maintain weight after 1 year. Which I think is interesting to point out, those who didn't, regardless if they're on the drug, did not do well. Another thing, the placebo here, if they responded to placebo, they did well. So there's certainly, instead of looking at people who, and I don't like to use the term successful and not successful and failure, because I think that really is language that goes back to thinking that it's the patient's fault. But people who respond to a medication or even a diet or an exercise pattern, we should think about their response. And if the response is something like this, again, looking at the three-month area, about 12 weeks, we should think about using the drug. This is without diabetes, and this is with diabetes. See a little bit difference with the diabetes. But again, I think that goes into how we should manage people, and this is just a diagram of looking at that 3 to 5% after 12 weeks, and if that's hit, to continue the drug, and if not, we should think about discontinuing. So if there's a vignette that shows somebody who hasn't made a certain 3 to 5% weight after 12 weeks, then we should think, the answer may be something along the lines of discontinuing. And all the current drugs that have been approved since 2012, lorcaserin, Qsymia, which is Phentermine and Topiramate, liraglutide, which is Saxenda, and naltrexone bupropion, which is Contrave, these all have that kind of criteria embedded in their PIs. And this is a graph looking at, again, lorcaserin, but it shows interesting, I like it because it shows that at 1 year, they took half the drug, the intervention group, and pulled them off and put them back on placebo. And you see how nicely they went, that group at 1 year went back to placebo. Again, showing the effects that perhaps drugs should be used long-term. And if we take the drug away, that there may be weight regain. And this is just a picture of sort of the old paradigm of thinking about doing lifestyle modification first, and then for a small subset, think about pharmacotherapy and surgery based on BMI. But we know it's much more complex than that. And so therefore, when to think about obesity or anti-obesity medications should be probably more than just BMI criteria. But for the boards and for practice, we should think at first about BMI over 30 or BMI over 27 with a comorbidity. We should think about somebody who's already maximized that lifestyle intervention and perhaps even be weight stable. That gives us a better idea if this medication is going to work. I would continue only in those who respond to the medication like I just spoke about. And then if, like every other disease, if monotherapy isn't working, we should consider combination therapy, and I'll talk about that a little bit today. And again, thinking about long-term use. If this is really working within their brain or within their gut physiologically, then it makes sense to continue it. Question 3, which one of the following drug adverse effect contraindication pairings is incorrect? Orlistat with a vitamin deficiency, Phentermine topiramate with a cognitive impairment, lorcaserin with headaches, liraglutide with priapism, and naltrexone bupropion with seizures. A, B, raise your hands again, C, D, E. Yes, D. So D, liraglutide, it's actually lorcaserin that really is paired with priapism. This question, not a perfect question, so I'll talk a little bit about it. 55-year-old woman with class 2 obesity responds well to a commercial weight loss program and then is frustrated as she's stopped losing weight. Does that make, you guys have seen this kind of patient before? Okay. Boxes of Kleenex we've gone through. Hypertension, depression, and glaucoma on lisinopril, citalopram, and timolol drops. She's interested in weight loss medications. What's the next best step? Put her on Phentermine. Anybody for that? Put her on Phentermine topiramate or Qsymia, the small dose. Start her on lorcaserin. Start her on naltrexone bupropion. All right. So this is a little bit of a trick question. Think about first glaucoma being a indication when not to use something like topiramate or Phentermine. Secondly, there is a warning about using SSRIs with lorcaserin. Not a contraindication, but a warning, thinking that the increased risk of serotonin syndrome may happen. It wasn't seen in the trials, but it is on the label. And secondly would be bupropion's effects as well on acute angle glaucoma, increasing that. Though there is a paper that said that it might be even protective. So, but for the most part, bupropion, I think it also is a contraindication. So, not really a perfect answer here, but I wanted to read through them. Next question, 65-year-old with a class 1 obesity, type 2 diabetes, depression, nephrolithiasis, and migraines is concerned about her weight and considering pharmacotherapy. Which of the following medications should be used with caution? Liraglutide, Phentermine topiramate, again, hands, lorcaserin, or naltrexone bupropion. Which should be used with caution? So we think about the effects of topiramate and also zonisamide, which I'll talk about later, on increasing the risk of nephrolithiasis. Again, topiramate may be a very good drug for somebody who has migraines and who has obesity. But again, the risk of nephrolithiasis maybe we should think about. For a set of slides that I'm going to show you, and in your books as well, it's just going to show this kind of slide, and again showing potential targets in green, contraindications, and that's also including known sensitivities to the drug, but it's not a complete list, and also common side effects. I'm going to go over the mechanism of action, dosing, maybe titration directions, as well as some clinical advice. I think these should sum up each medication pretty concisely. So let's start with the first one. Phentermine. No real indications other than the person should have obesity by BMI criteria. I think about somebody who has an increased hunger, maybe a low metabolic rate like a postmenopausal woman, for example. Not for the purposes of Borbs, but clinical. I've used it in those who have Down's syndrome. Anyway, cardiovascular. We've always thought about the cardiovascular side effects. So contraindications are going to include things that make it worse. Cardiovascular disease, moderate to severe hypertension, cardiac arrhythmias, again, glaucoma we just discussed. And there's always been this lingering effects of the amphetamines that drugs like phentermine have an addictive property, and that actually gave the 3-month criteria for phentermine, which there should be a citizen's petition against that. Maybe someday we can write that up. But there's really no indication why phentermine can't be used beyond that. But that'll be on the contraindications if that's in a vignette for the purposes of the boards. Dry mouth, constipation, insomnia are very common. Palpitations, headaches, irritability are less common. Again, this works at norepinephrine, increasing norepinephrine. It may have some effects on serotonin and dopamine. Again, working in the brain, affecting appetite. There's both capsule forms as well as tablet forms. And it's used on a daily, once a day. It is a Scheduled 4 controlled substance, and you should know those, and we'll go over those. Blood pressure should be monitored. I tell people to be aware of caffeine intake. Obviously, if they're 6 cups of Joe a day plus phentermine, that could end up with some palpitations. Anyway, no evidence of addiction, as I said, no evidence of withdrawal. That's been well studied. There's no established relationship to valvulopathy, again, bringing up that fen-phen relationship. And then this may come up, may be used with caution in MAO inhibitors. Here's a patient who I actually put on phentermine after the green arrow showing a brief intervention of a lifestyle intervention, but after a year, she had plateaued for a while. I put her on phentermine. She lost 27% of body weight loss, not 20%, 7% of excess body weight, but total body weight loss, and has maintained it for the last 5 years on the drug. The small is when I decreased her to every other day. And again, this is one example of somebody who's responded very well. But it does show you those people who respond can really respond. And obviously, if she didn't meet the criteria for a response, I probably wouldn't have continued the drug. But I think she's lived a better life thus far. Sympathomimetics, there are a whole drug class of those which you see listed. Again, I think the important thing is phentermine is not an amphetamine. The short-term use was, again, due to concerns over addiction potential. And again, I think this is something that we should tell the FDA about at some future point. But anyway, addiction only with amphetamines, not with bupropion. Not with diethylpropion, which is a similar mechanism of action, again, looking at norepinephrine. I don't see how diethylpropion, phentermine, and the next one will really be differentiated on an exam because many of the things are the same. The dosing here is just 25 milligrams TID. That can be also used in a sustained release. Perhaps maybe a little bit weaker sympathomimetic effects versus phentermine, but otherwise a very similar medication. Excuse me. Phendimetrazine is also similar. I think the difference here is that it's a Scheduled 3 controlled substance. Again, it has a different dosing criteria, as you see, 3 times a day or once a day. And again, like the class, there's no relationship with addiction or withdrawal. Orlistat. So Orlistat came along appropriately in the 1980s in its development and approved in the 90s, and it blocks pancreatic lipase. So we know that pancreatic lipase is important of the breakdown of lipids, ingested lipids, and this seems to block about 30% of ingested fat. Again, it's going to cleave longer chain fatty acids, regardless of whether they're unsaturated or saturated, but those under about 14 carbon lengths don't get cleaved. But certainly you can see if you're blocking long-chain fatty acids, that may not be that great in terms of overall health, because we know there's benefits of unsaturated fats. And also, if we look at fat-soluble vitamins, those are usually tagged with fatty acids, and so therefore we have to monitor vitamins with this medication. But we know that ingestion of fat isn't the cause of obesity, as was once thought. So this medication may not be as highly or commonly used as much. But again, those who have hypercholesterolemia or maybe some cardiovascular risk, thinking about reduction in lipids, this may be helpful. Certainly not to be used in those who have chronic malabsorption or cholestasis. And then I'm sure you've all heard about the GI side effects, so I'm not going to go into the specifics, but you can see them listed there. Increased urinary oxalate may be something to pay attention to. There were some case studies, or not a case study, but maybe just a patient study that looked at the risk of hepatitis in a few. So maybe think about that, but I'm sure that probably is not going to be tested. As I said, I'm not going to go through all the trials of these medications. This is my summary slide, looking at the lorcaserin in blue, Qsymia or Phentermine Topiramate combination in pink, naltrexone bupropion combination in green, and liraglutide in orange. And you see the effects in percent body weight change, and you see the placebo arm in gray. So again, not too exciting if we look at them as a class of medications. Someone may not be too excited to prescribe, let's say, lorcaserin if you're only going to get 3% body weight change after a year or two. Certainly, if we look at efficacy, the combination of phentermine and topiramate is most effective. Question. 29-year-old with BMI of 36 referred by the OB/GYN physician to help lose weight in order to increase her chances of getting pregnant. This is something that we commonly see. She has not had a period in over a year and has not taken contraception. She's been unable to conceive with her husband, who had a negative fertility testing. When considering medications, which one of the following is the best choice? So someone who's trying to get pregnant, even though that she's had a difficult being pregnant. How many out there think it's topiramate? What about phentermine and topiramate combination? What about C, lorcaserin, or D, metformin? So PCOS, perhaps, but what happens if she does get pregnant? And this also comes up. You have somebody on a medication doing very well, just like the woman who I showed you before, but then she wants to get pregnant. But you know some of these medications are contraindicated in pregnancy. There was a study recently about metformin in reducing pregnancy-related weight gain. So I think it's a safe medication to be used there. So how about this combination of phentermine and topiramate? It's the most effective medication out there. It has the combined effects of phentermine and topiramate. Again, topiramate is an anti-migraine, anti-seizure medication, which we actually don't know the true effects of how it causes weight loss. But I do list that AMPA or the GABA A receptors, those might decrease cravings. Animal studies with topiramate have actually looked at increased energy expenditure. The contraindications are going to be the same. You're going to tack on one or two things with topiramate, glaucoma being one of those. Paresthesias, if you have somebody on topiramate who's got a poor taste in their mouth, that may not be helpful for them, and that may be a side effect. Cognitive impairment, specifically word-finding difficulty, which I think I have a slide on this as well. So highlights here, there is a starting dose. So with this medication, you have 2 weeks on the lowest dose, which is 3.25 milligrams of phentermine with 23 milligrams of topiramate. After 2 weeks on that, you're supposed to increase to the regular dose, which is 7.5 and 46. Again, I don't have a picture here, but I have a patient who we started on that first dose, the low dose, and she did really well. So we just kept her on that dose. And she lost about 85 pounds over the course of a year on the lowest dose. Again, showing you that there's these high responders in some circumstances. Pregnancy warning because of topiramate causing oral palatal cleft lips as well. So there should be a pregnancy test before and then monthly thereafter on this medication. This is looking at just the responders of some of the trials with this medication. Again, I want to just point out that here we see in that very low dose, there can be very high responders. So you see the columns on the left looking at 5% weight loss, the one in the middle looking at 10% weight loss, and the one on the right looking at 15% weight loss. So 7.3% of the patients lost more than 15% of their body weight on this lowest dose of the medication. Pretty interesting. Yeah, I do have a slide on Topamax or Topiramate. Again, the mechanism of action of this drug is unclear. There's several different possibilities. I put in excess cravings. Again, this isn't testable, but I always give the story of patients that I have who have this incessant thinking about food. And I married an Italian, so that's sort of normal. But I mean people really who are thinking about when they're going to have their next meal, what they're going to cook, and it actually is intrusive in their thoughts. This medication is almost like turning off the switch in these people's brains. So if you have that patient, maybe this medication may be helpful. It certainly has an effect on carbohydrate cravings. And then again, a lot of the times you can think about the double benefit of this medication. If they have a migraine, if they have had seizures, it's been used with peripheral neuropathies. But I think the important thing is to know that if they respond, then that might be helpful. We should know about the warnings, acute angle glaucoma, that was what we just had a question on. Also suicide ideation and pregnancy, which I just spoke of. Paresthesias, specifically numbness and tingling in the fingers and toes. The cognitive impairment is that word-finding difficulty. Taste aversion, as I just explained. But also if someone who's drinking, I'm sure you probably have patients who drink a lot of soda. I had someone who was drinking about 6 liters of soda a day. I don't understand how someone can drink 6 liters of anything, quite frankly, but 6 liters, and openly admitted it. And actually this medication has some interactions with carbonated beverages. So actually this was helpful in one of my patients. You should know that it has interactions with oral contraceptive pills, again, being concerned about the pre-menopausal women. Metformin it has an interaction with, as well as hydrochlorothiazide. Again, use birth control because of the clefts, the oral palatal clefts risk. And that risk really is in those who are on this medication for seizures. There haven't been any of these findings in the studies over the last 10 years with the medication used for weight loss. Lorcaserin, as was well explained by Dr. Seacat, works at the Pom-C area. It's looking at the 5-H2 or serotonin 2C receptor. And the 2C receptor, I think I have another slide that shows this, right? But anyway, it may be helpful in those women who are of childbearing age. It has very little cardiovascular risk. The congestive heart failure contraindication is because serotonin levels are increased in those who have congestive heart failure. It works in the level of serotonin, so depression, ongoing depression may be a contraindication. Headaches, nausea, dizziness, and nasopharyngitis are the common side effects. It is a class 4 controlled substance. We talked in that one question, we talked about serotonin reuptake inhibitors and being cautionary because of the risk of serotonin syndrome. That's probably about that. And this is just a graph looking at the serotonin receptors as a whole. And it was very well introduced by Dr. Seacat. And this, again, is looking at the reasons behind the development of this drug, as well as the reasons behind fen-phen. Fenfluramine worked at the serotonin 2B receptor, which was great because in the brain it increases serotonin and decreased appetite through POMC, as you just saw. But it also, the serotonin 2B receptors were found in the heart, in the cardiac myocytes. Those hypertrophied caused a valve problem, and in some it led to valvulopathy and congestive heart failure and death. The serotonin 2C, so lorcaserin has about 100-fold increased affinity for serotonin 2C. So really, there's really not much peripheral action of this medication. Again, serotonin in the brain, appetite suppression. The other little caveat with lorcaserin is its independent effect on diabetes. We see one of the trials here looking at over 600 people after a year. Those who have stage 2 obesity, or excuse me, class 2 obesity, as well as an uncontrolled 7 to 10% A1C. They were also on oral contraceptives, and you see in the left-hand graph the reduction in the A1C in this group. So thinking about this medication potentially with diabetes would be a good indication. Question 7, a 42-year-old with a BMI of 33 with depression and metabolic syndrome who's been weight stable for the last 2 years after responding very well to a self-directed weight loss attempt using an app on her phone and home delivery service. She can't lose weight despite having a healthy lifestyle, and now, misprint here, she, now she is more hungry. She's so desperate to lose weight that she started to vomit after meals. Which one of the following medications is contraindicated? A, Topiramate, B, Qsymia, Phentermine Topiramate, C, lorcaserin, or D, bupropion. Not a lot of hands, but we know that bupropion can increase the risk of seizures in those who have active bulimia. On to the next question. Which of the following statements about the use of naltrexone bupropion is false? A, hepatotoxicity is a precaution because the cases of hepatitis have been observed with naltrexone. B, risk of seizure may be minimized by adhering to the recommendations of the dosing schedule. C, the risk of seizure may be minimized by avoiding a high-fat diet. Or D, it is not contraindicated in pregnant women. So this medication can be used. I think about people who have smoker or alcohol dependency. If you already have somebody who's on Wellbutrin for something else, maybe adding the combination may be helpful from a weight perspective. This mechanism of action works at dopamine and norepinephrine. Again, working at that POMC neuron. The interesting thing about the combination is that the naltrexone blocks an already built-in autoinhibitor of bupropion. So as bupropion increases the throughput into POMC, increasing its output there, naltrexone, there already is a POMC autoinhibitor, so naltrexone blocks this, allowing for more throughput. I think I have a picture on this. People who have seizures, uncontrolled hypertension, again, the stimulant effects of bupropion, bulimia I touched on, or chronic opioid use. We know that Narcan, which is also naltrexone, is used in those who have problems with morphine. And so if you're already on opioids for musculoskeletal problems or other, this may be something that's going to be inhibitory with the naltrexone. The warnings are for neuropsychiatric reactions, suicidal thoughts and behavior. Also, nausea is a big component of this medication if it does occur. This has a titrating dose over every week. You titrate up one pill or one tablet, and the tablet consists of 8 milligrams of naltrexone and 90 milligrams of bupropion, and that's increased over 4 weeks. Again, in divided doses, 1, then 2, then doubling up on each as you go. The trial, when it was first evaluated for approval in 2012, first in 2012, it was up for approval by the FDA and it was rejected. They had to do a trial looking at cardiovascular events. And so that trial is called the LIGHT trial. And so 4 years later, looking at cardiovascular events does not show a reduction in the population on naltrexone bupropion combination. High-fat diet may be testable. Again, it increases the bioavailability of the drug. Here's just a diagram of how the medication works. Again, the naltrexone working at the level of beta-endorphin, and the beta-endorphin acts as a brake. So what the naltrexone does, it blocks that brake. And again, you're having more throughput of the bupropion effect. These are the trials, a summary of all the trials with this drug. Again, looking at the common side effects, nausea, headache, constipation, and dry mouth. Again, there was no evidence of the negative effects on depression or suicidality, even though it is a warning. Liraglutide was approved for weight loss in the winter of 2014 at the 3.0 level. So it was already approved medication called Victoza, up to the level of 1.8 milligrams a day, and they do have an indication now for obesity. Again, it's a medication primarily used in people who have obesity and diabetes, but primarily, diabetes. But now we see that there is an indication for obesity. Obviously, the person that would benefit is the double benefit of diabetes and having obesity. We've heard a little bit about the medullary thyroid cancer risk, and they have that as a precaution, a contraindication, as well as MEN type 2. Again, there haven't been any human data that shows an increased risk of medullary thyroid cancer with this drug, nor is there data on an increased risk of pancreatic ductal neoplasia or pancreatic cancer. We do have to worry about nausea in this population. Headaches do occur. Renal impairment, we all have to adjust the doses of this medication. And that's about it for this. The other thing I would mention is that it also can be up-titrated. So it comes in a pen, and the pen is dialed from 0.6 to 1.2 to 1.8 to 2.4 to 3.0. So this can be titrated over the course of weeks as tolerated. These are the common side effects listed here of the medication. Again, nausea, diarrhea, constipation, vomiting, so GI type. It does decrease so you think about decreased gastric emptying, causing problems in the population on this drug. This is a study, and the study is called Duration 6, looking at the effects head-to-head of liraglutide. This is looking at the 1.8 dose versus exenatide, which is also called Byetta. The exenatide is available in a weekly dose called Bydureon. And so the head-to-head trial was done here in people who have type 2 diabetes. You see that the liraglutide is in green, the exenatide, the once weekly, is in blue. There is a very small weight difference between the two. It says 2 pounds here. It should say 2 kilograms. That's a typo in the second line of my conclusions here. And then on the right-hand side, you do see the risk, and this is why I wanted to show this slide. You do see the risk of getting side effects. But you see over time, these side effects dissipate. So it's really within those first few weeks that if there are going to be side effects of this drug, they're going to occur. So clinically, for some of my patients, I might tell them before I prescribe it that they may have these side effects at any point. And if they do and they're already at an advanced dose, they could actually decrease. Just like we would say that for the weight loss effects. If somebody already is reaching satiety with a 0.6 milligram dose, then there's no real need to continue to increase, even though the trials show us that at the 3.0 level there is this weight loss effect. Again, I want you all to think about responders to these medications. Exenatide is much like liraglutide in terms of its effects mimicking GLP-1. So there's not much difference here other than there is this weekly dose called Bydureon. Everything else is about the same. This is a study looking at the effects of adding exenatide to those who are already on insulin, showing effect on weight as well as diabetes. Again, we have a very good diabetes program at our hospital. There are a lot of leaders, and they're very specific about what they do and very confident. And when this first came out, I remember suggesting this to one of the diabetologists who balked at me and saying, well, we're only insulin here. This is all we do. But now we're seeing very good evidence of combination therapy on those who have, who are already on insulin. The SGLT2 inhibitors have come out recently, and we've heard about them in terms of their effects on weight. Primarily, these are diabetes medications. Again, looking at the reabsorption of glucose. By blocking the reabsorption of glucose, you have more glucoseuria. And that was the main reason how we thought, and many of the studies looked at the effects of glucoseuria, losing about 300 calories a day, and that can be having some effects on weight. There actually is a recent study over the last few months that looked at the medication in terms of an alternate effect, weight loss effect of the medications, meaning the SGLT2s, that they may increase fat absorption. The normal glycemic ketoacidosis, there have been a few cases. I don't know, again, if this is going to be testable, but there have been a few cases over the last year or so that have been described in people on SGLT2 inhibitors. But candidiasis, UTIs have been sort of the more common side effects that would be listed. Again, in terms of monitoring for renal function would be the one caution that you have to look for is hyperkalemia. And again, this dose is available at 100 milligram capsules. Of the newer medications we see on the right-hand side, we see the effects on cardiovascular effects. The only thing I would mention would be that the increase of systolic blood pressure was found in the Contrave trials. Everything else would increase or decrease naturally, as we would think, with weight loss. Zonisamide isn't a very well-known medication. Even the neurologists who would primarily use this drug aren't really familiar with the drug. It has been used and studied for weight loss, though there's nothing evaluated recently. It's sort of like a cousin of Topiramate. It also enhances serotonin and dopamine, and it's a carbonic anhydrase. So it's an anti-seizure medication, also an anti-migraine medication. It seems to have a lot of effects, the side effects of sleepiness. So those people who are overweight or have obesity already, who have problems with their sleep, sometimes I've taken them off their Seroquel and put them on Zonisamide. Again, it also has been used in combination with bupropion. That study was done about 10 years ago. It has a sulfa moiety on it, so anybody who has a sulfa allergy should not be on this medication. And there also have been reports of Stevens-Johnson syndrome on this medication. But the main side effects in terms of somnolence, as I described, nephrolithiasis, glaucoma, these things sort of go hand in hand, much like Topiramate. Monitoring renal function as well as watching the interactions with naproxen and ginkgo biloba. Those have been reported. The naproxen really is along that sulfa allergy or sulfa moiety. Question 9, a 51-year-old female patient with a BMI of 37, type 2 diabetes, and dyslipidemia has been treated with metformin, lovastatin for years. She returns for a routine visit and complains of tongue burning and tingling in her feet. Which of the following is the best explanation of her symptoms? Tongue burning, tingling in her feet on type 2 diabetes on metformin, lovastatin. A, thiamine deficiency. Who thinks it's a thiamine deficiency? B, vitamin C or ascorbic acid deficiency. C, riboflavin deficiency. Or D, cobalamin or B12 deficiency. Yeah. So cobalamin or B12 deficiency has been shown and reported in those on metformin. The actual mechanism of action of why that happens is not known. Metformin doesn't seem to do anything with, let's say, intrinsic factor or B12 itself. Again, these are just reported side effects. So metformin, we've heard about it, we know about it. There are studies that have been used in people who have prediabetes or impaired glucose tolerance with this drug. It activates AMP kinase and decreases hepatic glucose production. For the most part, this drug has been used and thought of as something that helps us with insulin resistance. It makes the body more insulin sensitive. And there also have been a lot of warnings about lactic acidosis in this drug. But I think our knowledge of the drug has changed recently. We know that the long-acting, I'm sure you've all experienced the person who has diarrhea or cramps on this medication and you've switched them to the long-acting. And then miraculously, almost, they've done very well with the long-acting drug. Why does that happen? Well, research that I'm not going to go into more recently has looked at the effects of this drug on the actual, in the gut, and maybe its effects in the gut through AMP kinase may be one of the effects of this drug in terms of its ability to work with diabetes. I will say that I list here as one of the indications of looking at atypical antipsychotic medication-induced weight gain. So those who are specifically on second-generation atypical antipsychotics, those medications act at the histamine 1 receptors in the brain, and metformin seems to also act at that receptor, and I'll talk about that a little later. The reports of lactic acidosis, there actually was a citizen's petition that was written in about 4 years ago, and then this April it was approved, and basically states that you can use metformin in those with a GFR above. They look at 60 being the cutoff, but you can use this in people who have mild renal impairment. So the FDA is switching all its warning labels, and this was done through a citizen's petition recently. But if it's on a test, lactic acidosis would be one of the things you have to worry about with this drug. Looking at DEA scheduling, this is just a synopsis of the scheduling and what the definitions are. Looking at Schedule 1 being the more concerning, and also looking at Schedule 4 like phentermine and diethylpropion being a little bit on the safer side. I will mention the lisdexamfetamine, I can't say it very well, lisdexamfetamine or amphetamine, which is also Vyvanse. You may have heard of it. A lot of patients ask about this. Again, this is a Schedule 2 drug, so it has high potential for abuse. It may lead to severe psychological, physical dependence. And that's right up there with Adderall and Ritalin. That's actually where it's used. But I personally have not used it for weight loss. And then you see the other medications, the Phendimetrazine being a Schedule 3, and then Schedule 4, as I said, some of the drugs that we use. For these drugs, you need a hard copy and you need your DEA number on it. So these are sort of the prescription pathway that you have to go through. You can't prescribe it over 6 months, and then the verbal order can go in, but you need a hard copy to back it up. And I should note that prescribing laws vary by states, and I'll leave it at that for, again, purposes of the boards. Also, you may know that there are these risk evaluation and mitigation strategies that have been implemented for 2 drugs, Qsymia, that combination of phentermine and topiramate, as well as for Saxenda, and you see the listings there, and we've gone over this already. But again, this is post-marketing drug safety. So these are done just to continue with safety. Anyway, question 10. 47-year-old male with a BMI of 33, type 2 diabetes, A1C is 7.5, lost 6 pounds after 3 weeks on metformin, extended release, but he developed diarrhea and he was changed to glyburide by his PCP. After 2 months, he's gained some weight. After discontinuing the glyburide, which of the following medications would be most appropriate? Pretty straightforward. Insulin, sitagliptin, pioglitazone, or D, liraglutide. You think about the the GLP-1 agonists in this case. How about a 52-year-old with a BMI of 33, type 2 diabetes and depression who's concerned about a 25-pound gain since he was diagnosed with hypertension and dyslipidemia 2 years ago. He denies changes in his diet, exercise, or sleep patterns. He's taking metformin, citalopram, metoprolol, simvastatin. What's the next best step? How many of you think you should stop the metoprolol and start diltiazem? How about stopping the metoprolol and starting carvedilol? How about stopping the antidepressant and starting citalopram? How about stopping the citalopram and starting aripiprazole? Or the last one, what about observing for 3 months and then starting on lorcaserin? So not a lot of hands here, but I want to get at beta blockers. And so we know that some medications cause weight gain. This is a study, the UKPDS trial, which was a great 10-year long study that looked in diabetics, and this is just a graph showing the effects of insulin as well as sulfonylureas, which used to be that second tier for people who have diabetes on metformin. But obviously we know that they cause weight gain. And so this was actually shown by Dr. Seekatz as well, and I would agree, trying to get people off medications might be the first thing you do in managing somebody's weight. Getting someone off of sulfonylurea and adding a GLP-1 agonist or an SGLT2 inhibitor, etc., may be the first step that you take. This is a graph looking at, again, more weight neutral or weight loss drugs compared to ones that promote weight. Again, in people with diabetes, let's think about treating their obesity as well. And this is just a list of potential weight gain promoting medications that you've seen already. I would say I've seen tamoxifen and weight promoting effects of tamoxifen. In terms of OCPs, it's really Depo-Provera, which is the one to be aware of. And this is a study looking at atypical antipsychotics, which are also very well known for weight promotion. And this is the mechanisms by which they may work. Again, I wanted to talk to the histamine 1 receptors causing food intake. And that mechanism, again, is shown here, and also maybe through blocking that 5-HTC2C receptor. So how lorcaserin works, we know by blocking that, these may enhance that serotonin effect. This is the Gemini study that looked over 1,000 type 2 diabetics who also have hypertension, placed on metoprolol or carvedilol, and you see the weight difference there. When looking at the change in weight, you see that those who have obesity actually are more affected if they had a BMI over 40. So really taking a look of why the person is on a beta blocker. Obviously, if they have cardiovascular disease, they'll have to stay on it. But maybe simple changing of the beta blocker may be very helpful for those who have severe obesity. And this is what to do in those people who already have weight gain and have to be continued on these medications, specifically the atypical antipsychotics. And both metformin and topiramate have been used and well studied in this medication, with this group. And this is just a person who was on aripiprazole and lost weight after being taken off the drug. This is, for the sake of time, I'm just going to say that this is the summary of dietary supplements. In the middle, you have increasing fat oxidation. Hydrocitric acid is how Qsymia works. And green tea, the catechins, catechins, that's how that medication, that's how that works. Don't use ephedra, and these are the reasons why. And Qsymia, really, as much as it's touted, doesn't really have any too many exciting effects on body weight. And my time is up, but really looking at combination therapies was the last thing I was going to look at. There are many different combinations out there, but we haven't looked at the long-term effects of them. But I would say that some patients do very well on different combinations. And this is a person who I put on 2 different medications, and she's done very well. Again, there is that metformin-topiramate interaction. And then last slide, looking at somebody who's already done very well with surgery, losing 35% of her body weight. I put her on Topiramate last year, and she's lost 120 pounds. Over 65% of her body weight is gone, and she's done very well. So there are effects of these medications in different scenarios. Overall, we should think about obesity as a very heterogeneous disease, and therefore the treatment plan is like trying on a pair of shoes. I use this because my wife likes shoes, and it's often finding the right pair of shoes that works, and that's what we should think about when using medications. If it doesn't work, get rid of it. If it works, continue. So good luck on your exam, and thank you for listening.